Hi, I'm Christine McDonough, Assistant Professor in Physical Therapy and Orthopedic Surgery at the University of Pittsburgh. So happy to be with you. I am going to start off the discussion of the recommendations and interventions, and I'll just highlight a few things to orient to start with. The three main categories of recommendations are, number one, recommendations that cross the entire episode of care and the related settings. Number two, the recommendations that apply in the acute setting. So the acute care hospitalization, inpatient rehabilitation, and or skilled nursing facility. And then number three, the later rehab, which occurs in the community in either the home care setting or outpatient setting. And then the second thing that I wanted to just mention is the briefest review of methods, which is that we did systematic reviews of the literature for published studies and interventions. We focused on systematic reviews and meta-analyses were available. In the areas of practice that were more interprofessional, that were not the focus of the clinical practice guideline, we used existing high-quality clinical practice guidelines and conducted a systematic critical appraisal of those guidelines. We only included high-quality guidelines, and we'll discuss a little bit more about those later, and more details are provided in the guidelines. We had two main categories of recommendations that applied across the continuum of care. The first is structured exercise, which I'll define in a minute. And then the second was interprofessional management, which we're defining in this case as situations in which two or more professionals are working together, collaborating, learning from each other, and contributing to the well-being of the patient. So our first, and it's a really pretty large recommendation covering a good deal of physical therapist practice because it's across the continuum of care and it's multi-component. This one is described as structured exercise, and it includes progressive strength training, balance training, weight-bearing exercise, and functional mobility training. So that's a lot. But this particular recommendation is a strong recommendation based on level 1 evidence, and it states that clinicians must provide structured exercise, including progressive, high-intensity, resistive strength, balance, weight-bearing, and functional mobility training. This is based on multiple systematic reviews and meta-analyses, and the bottom line from them is that there was clinically significant small to moderate impacts on mobility and physical function of these interventions in different combinations. Our clinical practice guideline has lots of detail on what that all means. Appendix J is a good one to look at, but essentially what we found is that the impacts were important, and that the clinical practice guideline development group actually felt that there may be unmeasured benefits in terms of fall prevention and secondary fracture that had to be taken into account, that went into this really strong recommendation to provide structured exercise. Examples of structured exercise include progressive high-intensity resistive quads training, as shown in the picture here, weight-bearing exercise, such as forward step-ups, lateral step-ups, forward foot taps, and with progression based on the height of the step. There's also potentially repeated sit-to-stand functional mobility training with progression based on lowering of the seat height. So progression is a really important part of these interventions. There must be progressive, there must be high-intensity aspects to these interventions. More details in the Appendix J and CPG. We want to note also that we provided a separate recommendation of moderate strength based on level 3 evidence, which came from systematic reviews of cohort studies that showed that essentially individuals with cognitive impairment, mild to moderate dementia, had similar relative effects or relative impacts of interventions as those without. And so as a result, the clinical practice guideline development group recommended that clinicians should provide physical therapy or rehabilitation to patients with mild to moderate dementia using similar interventions and prescriptions as to those without. So to now make a switch into interprofessional management, the bulk of these recommendations are coming from high quality clinical practice guidelines that already exist. And so the first one is on prevention of falls, which is extremely important for people with hip fracture whom we know are already at risk for falls, who likely got the hip fracture from a fall. So we have an A recommendation, which is strong based on a high quality clinical practice guideline that states that clinicians must assess and document risk factors for falls and contribute to interprofessional management. And we specifically recommended that physical therapists use the Academy of Geriatric Physical Therapy's clinical practice guideline for fall risk management. This recommendation addresses prevention and identification of delirium, and it's based on a high quality clinical practice guideline from the National Institute on Health and Care Excellence in the UK, focused on post-surgical delirium in older adults. And based on this strong evidence, the clinical practice guideline development team developed a recommendation that physical therapists should participate in multi-component non-pharmacologic intervention programs delivered by an interprofessional team for the entire hospitalization in at-risk older adults at risk of delirium. This recommendation is based on a consensus statement from a high-quality clinical practice guideline from the National Institute on Health and Care Excellence in the UK. And it states that physical therapists must assess hip fracture-related pain at rest and during activity and implement strategies to minimize the patient's pain during the treatment session and to optimize patient's mobility. Two aspects that are critical to the overall outcome and also important to the prior recommendation of delirium identification and prevention. So strategies are noted in this recommendation, including timing of medication, consultation with interprofessional team, and other approaches. This pain assessment and management recommendation is based on expert opinion. Also based on high quality clinical practice guideline in hip fracture management, this recommendation for prevention of pressure ulcers is based on expert opinion because in the clinical practice guideline, it was a consensus statement. Our clinical practice guideline development team agreed and provided the statement that clinicians must screen for risk of pressure ulcers. Again, note that we say clinicians, meaning that it could be the physical therapist, it could be another member of the interprofessional team. Risk factors are noted as including limited mobility, loss of sensation, previous ulcer, nutritional deficiency, inability to move and reposition, incontinence, and cognitive impairment. We have also a recommendation on secondary fracture prevention. Although osteoporosis identification and management is outside of the scope of physical therapist practice, the reality is that many physical therapists practice in a health system or delivery system in which things like fracture liaison services or other osteoporosis management systems are available. And so the clinical practice guideline development team identified this based on expert opinion that physical therapists should contribute to interprofessional care to ensure that older adults with hip fracture are appropriately evaluated and treated for osteoporosis and risk of future fractures. And this is an F. The final two interprofessional recommendations across the continuum of care address functional assistance requirements and identification of individual goals. And although they may be perceived as standard practice for physical therapists, the quality improvement opportunities for consistently addressing these two issues were so compelling as to require expert opinion-based recommendations from the clinical practice guideline development team. So here they are. Determination and communication of functional assistance requirements. An F, based on expert opinion. Physical therapists must provide guidance to the interprofessional team and patients on assistive devices and assistance level for transfers and ambulation for patients with hip fracture. And then for identification of individual goals, physical therapists must elicit individual goals for recovery of function, which may include independent basic mobility, achieving prior level of function, returning to pre-fracture residence, and or activities to support long-term well-being. And these goals should be reviewed and revised throughout the continuum of care. And with that, I will let you move on to the early postoperative recommendations provided in the next session.